I've been asked to talk a little bit about fertility preservation and what options are available for patients with desmoid tumors and certain concerns that we may have. So as we know, there is a risk of infertility with certain types of treatments. There are also a variety of factors that may influence fertility after treatment. These include things like chemotherapy, radiation, what types of chemotherapy were used, what doses of radiation, where were people radiated, any prior treatments that any patients may have received, patient's age, especially in women, doses, radiation, as well as the gender. Specifically with desmoid tumors, we also know that many can be hormonally sensitive, especially to estrogen. And some patients may experience accelerated tumor growth during high estrogen states, for example, pregnancy. The tumor location may also pose issues. This can impact reproductive organs and may also affect treatment options. Tumors in the abdomen or pelvis are especially relevant to fertility planning. And then we also know that patients with familial adenomatous polyposis, or FAP, desmoid tumors can be a severe complication, and treatment plans need to account for any genetic factors that may be involved. So this is a caveat. I'm a fertility specialist for women, so I don't really take care of men. So just a plug out there that there are options for men as well. Sperm banking is considered the gold standard for men, as well as radiation shielding. It may protect prepubertal or postpubertal males receiving radiation. However, this would not protect from any forms of chemotherapy. There's also experimental options, including testicular cryopreservation, mainly used in prepubertal males, but may also be used in postpubertal males. This is a research protocol at selected centers throughout the U.S. That involves a surgical wedge resection of the testicle. And the idea here is that there may be a potential for repopulation of gonadal stem cells in the future. This is experimental at this time. There's also hormonal suppression that could be used. However, there is contradictory evidence of efficacy with any hormonal suppression. So how about females? So as women, we are born with the maximum number of eggs that we are ever going to have in our life. And by puberty, that number has decreased from about 1 million at birth to about 300,000. And then by the age of 51, which is the average age of menopause in the US, the majority of the follicular pool has been depleted. So what can happen with treatments is that we can experience an acceleration of the ovarian decline. So that if a biological woman is 30, her fertility may mimic someone who is in their 40s or even menopausal. So what options are available? We can do embryo or oocyte cryopreservation. This involves doing an IVF cycle. There's something called urferpexic that can be done where if patients are receiving radiation, the ovaries can be placed outside of the radiation field. There can be ovarian shielding, similar to testicular shielding, just with covers over the ovaries. Hormonal suppression, there is conflicting data regarding usefulness of any type of suppression. Fertility-sparing surgeries for certain types and stages of GYN malignancies or any tumors involving the GYN organs. And we also have to think about third-party reproduction, including donor egg or potentially gestational carriers if a patient cannot undergo pregnancy. So oocyte or embryo cryopreservation entails going through the first half of an IVF cycle, and then we either fertilize the eggs to create embryos or we freeze eggs which are unfertilized. In the past, egg freezing didn't have as good of success rates because the freezing and thawing methods were not as good, but with the introduction of vitrification, which is a newer technique for freezing eggs and embryos, we get almost equivalent success rates in terms of thaw survival with eggs as well as embryos. But for any individual patient, what should they choose, eggs or embryos? So a lot of that has to do with what their partner status is. Are they in a stable relationship? Is the relationship not stable? Any ethical or religious concerns about freezing embryos? And also realizing that genetic testing can really only be performed once an embryo is created, and that we can better assess the quality of the egg when it's actually fertilized. So although the thought survival may be similar between eggs and embryos, we're better able to assess egg quality if it is allowed to be fertilized. So what's involved in a fertility preservation cycle? An ovarian stimulation, which generally involves 8 to 14 days of self-injected hormones, during which time most people come in about 5 to 9 times for blood work and ultrasound to assess how they're responding to medications and to make medication adjustments. An egg retrieval or an oocyte retrieval, which is typically done under conscious sedation, so patient is asleep, and then under ultrasound guidance, there's a needle that goes through the back of the vagina and into the ovary to aspirate or suck out all the follicles. If the patient is fertilizing, we will then expose those eggs to sperm, or we will cryopreserve any mature eggs, or with embryos, we generally grow them to what's called blastocyst stage, which is a normally growing embryo on day 5 through 7 of embryo development. It's at this stage that if genetic testing is being done, that the genetic testing would be done prior to freezing the embryos. At a later date, the embryos could be thawed and transferred, or in the setting of eggs, the eggs would have to be thawed, fertilized, and then transferred. Generally, in cases where we're doing fertility preservation and we don't have a lot of time, we generally use what's called an antagonist protocol. And an antagonist protocol allows us to quickly start medications, regardless of the timing in the menstrual cycle. The medications are generally a combination of follicular stimulating hormone with some type of LH, either with recombinant form or through other medications. And then during the time of the stimulation, there is an antagonist that's added, and the antagonist basically prevents premature ovulation. For desmoid tumors, when we're concerned about estrogen and the rising estrogen levels, we can also use a medication called letrozole, which is an aromatase inhibitor. And this medication will lower the circulating levels of estradiol. So the gonadotropins are given for 8 to 14 days. Letrozole is given throughout. And then there's a trigger shot, which is done to induce the final maturation of the egg. And then 36 hours later is when the patient undergoes the egg retrieval. So the stimulation protocols can be cycle-specific, meaning they start along with a period, or they can be what's called random start, which basically means regardless of the period. Success rates are the same regardless. And monitoring and ultrasounds are about 5 to 9 times during that time period. And again, the letrozole medication can be used throughout to diminish the levels of estradiol. So this is what a typical kind of ultrasound wand looks like. You can see the vaginal probe right over here, and the proximity of the end of that vaginal probe to the ovary. There's a little needle device that goes on top that allows us to poke through the back of the vagina and into the ovary. The fluid that we aspirate is then given to the lab in a little test tube, and the lab identifies the egg. So this is an ultrasound image. So when we're doing retrievals, this is what we are looking at. And this little bright line right over here is actually what the needle looks like under ultrasound. The procedure itself takes about 10 to 20 minutes, so it's actually a fairly short procedure. Patients are generally with us for a couple hours just to make sure that they're doing okay after anesthesia. So this is a movie, but let's see if it'll play. So this is a movie of an egg retrieval. So in just a second, you'll see a needle. Yep, there's a needle, and it aspirates all the fluid that's inside of the follicle. And then we go to the next follicle and aspirate the fluid.
Yeah.
So it's actually kind of a fun procedure to do. it basically line up those follicles and then put the needle right on through. If we're fertilizing, there's one of two methods that can be used. There's either what's called conventional insemination, where sperm is placed next to an egg, or there's a procedure called intracytoplasmic sperm injection, where one sperm is directly injected into the egg for fertilization. A lot of times we'll use this more advanced technique if there's issues with the sperm, either sperm quality, quantity, or if we are dealing with very limited amount of sperm. The day after fertilization, what we'll want to see is what's called a 2PN. So this is a zygote, and you can see there's two nuclei, 1, 2. And so this is, when we see this, we know that the egg has indeed fertilized normally. So what about PGT, or pre-implantation genetic testing? I had mentioned this is something that can be done with embryos. This is an add-on or an optional add-on. It's not something that is done all the time. This allows us to screen embryos for chromosomal abnormalities, and this is called PGT-A, at the A standing for aneuploidy or chromosomal abnormalities. And it also allows us to be able to screen for single gene inherited disorders, that's called PGT-M. M stands for monogenic disorders. What this involves is growing embryos to blastocyst stage, again, day 5 through 7 of normal embryo development, and then taking a biopsy. The biopsy removes about 5 to 7 cells. The embryo itself is then cryopreserved, and these biopsied cells are sent to the genetics lab for testing. So as with everything, there are risks. There's a risk of bleeding, infection, damage to surrounding organs, including bowel and bladder, that happens less than 1 in 1,000. So overall, retrieval-related risks are fairly low. There's a risk of overstimulation, or something called ovarian hyperstimulation syndrome. This is, again, something that happens less than 1% of the time, but is more likely to happen in patients who are younger or who receive a certain type of trigger shot at the end to induce oocyte maturation. We also know that there is a small increased chance of pregnancy-related complications or neonatal issues with pregnancies that involved IVF. Specifically, birth defects in the general population happen about 2 to 3% of the time, but there is a slight increase with IVF conceived pregnancies at 2.6 to 3.9%, so a slight increase. Interestingly, this is the same slightly increased chance that's seen in couples with infertility who are able to achieve pregnancy without using IVF. So we think a lot of the birth defects and potentially pregnancy complications may be related to reasons why fertility treatments were being used as opposed to fertility treatments in and of themselves. But as you can imagine, those studies are very, very hard to do. There's also potentially an inability to survive a freeze and thaw. So with embryos, the thaw survival is about 98%. With eggs, it's about 85%. So pretty good, but certainly not 100% by any stretch of the imagination. And when we're dealing with very few numbers, even a 2% loss can be detrimental. When we're doing genetic testing, especially for aneuploidy, there is a false positive or false negative rate of about 2 to 4%. And again, when we're doing PGT, there's also the chance that we will end up with no usable embryos. So either with chromosomal abnormalities, or if we're doing the single gene testing, that all of them are affected. And because we don't get those results back for about 2 weeks of time, potentially by that time, patients would have already started treatment. So if we're doing an embryo transfer down the line, either autologous or into a gestational carrier, this usually involves an endometrial preparation. So the endometrial preparation is usually about 2-ish weeks, 2 to 3 weeks. And then the embryo is transferred into the uterus, very similar to a pap smear exam. So just with a speculum, it's non-sedated. Generally for this, if there's a partner involved at our institution, we will let them come. And it's generally done under ultrasound guidance. So the embryo is transferred through the cervix and into the uterus and dropped right around here. So success rates. These are the latest published success rates in the US. We can see that success rates do decrease as women get older, but in our youngest age groups, the success rate can be almost as high as 50% per cycle. That is all I have. Thank you.